Thank you for joining us today for our Heart of the Family Talk. Joining us today is Dr. Brian Howard. He is one of our Wellstar physicians out of the Heart Failure Clinic. He's going to be talking about heart failure. What is it? What are the symptoms? What causes it? The importance of diet and exercise, and how to manage it. Dr. Howard finished his clinical fellowship at Stanford University, specializing in advanced heart failure and cardiac transplant. Now I'm going to turn it over to Dr. Howard, who's going to talk about heart failure and how to make it into a heart success.
Thank you, Chelsea. So let's just get right started. I'm Dr. Howard, and what we're going to talk about today is what I believe to be very important for patients with heart failure and caregivers of patients with heart failure, and even the general community, anyone who's interested in learning a little bit more about what heart failure is and how to take care of it. And so we're going to cover some topics that I believe to be pivotal. Of course, we won't cover everything in heart failure, but we're going to cover some things that I think are very important and very appropriate for anyone who touches the world of heart failure. So we'll talk about what exactly is heart failure, because not everyone knows. What causes heart failure and how can I prevent it? What are the symptoms of heart failure? How do I stop my heart failure from getting worse? How does diet and exercise affect my heart failure? And what can I do if I'm doing everything my doctor's telling me, but I still don't feel good? And we'll finish talking about how really heart failure is a team approach, and I'll talk about how we can attack heart failure as a team and be triumphant, so we can turn heart failure into heart success. So, what is heart failure? Well, heart failure is a progressive medical condition that occurs when the heart can no longer adequately meet the demands of the body. It's typically accompanied by symptoms of congestion due to fluid retention. So it's often termed congestive heart failure. Heart failure does not mean your heart has stopped. When your heart is stopped, that's a cardiac arrest. Heart failure is just the syndrome or symptoms associated with the heart's inability to meet the body's demands. Heart failure patients can actually live for many, many years, unlike a patient with a cardiac arrest. And so most of my patients who have heart failure have a good quality of life. They're not in and out of the hospital, but this does require some work, and we'll talk about how to do that. So what causes heart failure? Well, heart failure can occur when the heart is weak so that it doesn't pump normally, but it also occurs when the heart is still strong but stiff so it doesn't relax normally. Both these things can cause heart failure, and the symptoms are very similar, if not the same. In both cases, the pressure inside of the heart gets high. This causes the symptoms, and the main symptoms we see are shortness of breath and swelling. We use the term ejection fraction to quantify how strong the heart is, and this ejection fraction quantification allows us to treat patients according to the right paradigm. So how do we measure ejection fraction? Well, we use a technology called echocardiography. So echocardiography, or an echocardiogram, is simply an ultrasound of the heart. It's the most common way to assess heart size and function. There are other ways, but these are a little bit more complicated. You can do a cardiac MRI, you can do a CAT scan, you can even do a nuclear scan. But ultrasound or echocardiography is very simple. We can do it at the bedside, we can do it very fast. It gives, in most patients, a very good estimate of how strong your heart is and how it's functioning. And so usually we get this ejection fraction from an echocardiogram. And this image right here displays a normal ejection fraction. A normal ejection fraction is about 55 to 60%. And as you can see from looking at the heart on this page, the heart has 4 chambers. The chamber on the top right of your screen is the left ventricle. That's the ventricle that pumps the blood to the rest of the body. And that's a normally functioning left ventricle. Ejection fraction of 55 to 60%, which is normal. Contrast that prior image to this current image. You can see they don't look the same. This heart is barely moving. This is a severely reduced ejection fraction, probably in the range of 15%. Very sick heart, and this patient needs to be treated very differently than the patient we just saw. So as we said, patients can have heart failure from weak hearts or strong hearts that are very stiff. When the heart is weak, it often becomes dilated, and we use the term cardiomyopathy to describe this type of dysfunction. Cardiomyopathy just means abnormal heart muscle, and there are many things that can cause a cardiomyopathy. So what causes a cardiomyopathy? Well, most commonly in this country, people get a cardiomyopathy from a major heart attack or major blockages inside the arteries that supply the heart. We call this an ischemic cardiomyopathy. And there are many different types of risk factors for ischemic cardiomyopathy. So anything we can do to minimize or treat the risk factors for ischemic cardiomyopathy will minimize the likelihood that a patient develops heart failure or that their heart failure gets worse. So what risk factors are those? Smoking, diabetes, hypertension, abnormal cholesterol or triglycerides, obesity or sedentary lifestyle, family history, and older age. All those things can contribute to blockages in the heart or a major heart attack. And if you look at the list here, you'll note that the first 5 things on the list are actually modifiable and often reversible with lifestyle modifications and treatment with medications. So one of the things we can do as medical practitioners and as patients is really focus on these risk factors to minimize the risk of progressive disease. Well, what else? What else can cause a cardiomyopathy? Well, poorly controlled hypertension in and of itself can cause a cardiomyopathy. We call that a hypertensive cardiomyopathy. So even outside of a blockage in the heart, if the blood pressure is very high for an extended period of time, that can make the heart weak. Illegal drugs such as crack, cocaine, crystal meth, all these things are directly toxic to the heart, and they can make the heart weak and cause a cardiomyopathy. That cardiomyopathy can then lead to heart failure. Even excessive alcohol consumption, and I'm not talking 1 or 2 glasses of wine every now and again, but regular daily drinking, usually excessive drinking every day, those folks can also develop an alcohol-induced cardiomyopathy. So all these things, blood pressure, illegal drugs, excessive heavy alcohol use, these are highly modifiable and reversible if they're diagnosed and treated early enough. If we meet a patient when they're too late in the disease process, often we cannot fix things. What else? Well, sometimes these cardiomyopathies are genetic. So your mother had a cardiomyopathy, your brother has a cardiomyopathy, and you have a cardiomyopathy. We call this a hereditary cardiomyopathy. Certain viruses, including COVID, can cause a cardiomyopathy. We call it a viral cardiomyopathy. Even childbirth, we call that a postpartum cardiomyopathy. Many young women get this. Sometimes that gets better, but sometimes these women struggle. And chemotherapeutic agents. So certain cancers require certain chemotherapeutic agents that can be directly toxic to the heart. And we call that a chemo-induced cardiomyopathy. So this is just a list of a few more things that can contribute to a weak heart and heart failure. But there are many, many more. Hormone imbalances, enzyme deficiencies, congenital heart defects, extreme obesity, and even stress can cause a cardiomyopathy. And more and more and more. So many things can cause this condition. Some are reversible, some are not. It's most important that we reverse the reversible conditions. That's the best way to improve the long-term outcome. So many of my patients will ask me, well, what if my heart isn't weak or dilated, but I still have heart failure? Well, actually, this is very common. These patients have heart failure with preserved ejection fraction, meaning the hearts are stiff, they don't relax normally, but they actually pump normally. Their strength is normal. So patients with these stiff hearts have symptoms that are very similar to patients with weak hearts. Again, we call this heart failure with preserved ejection fraction. So it is important to know your ejection fraction as a patient. Do I have a weak heart? Do I have a stiff heart? Is my ejection fraction normal or is it reduced? Because that's how we define what the treatment is. So I've talked about the symptoms of heart failure in a general sense, but I'd like to get a little bit more specific. What are the symptoms of heart failure? Well, the hallmark symptom of heart failure in most patients is going to be shortness of breath, particularly with exertion. They'll say, if I'm just sitting watching on the couch watching TV, everything's okay. But if I try to walk up a flight of steps, try to walk to the mailbox, if I try to walk even at a pace that's faster than slow, I get short of breath, I have to sit down and rest. Can't keep up with my significant other, or I used to be able to do this, but now when I try to do it, I can't do it anymore. I have to stop and rest. I can't get through it. Oftentimes, that's a hallmark of development of heart failure or worsening heart failure. Exercise intolerance. Patients that used to be able to exercise can no longer exercise. Swelling of the legs and or abdomen, we call that edema. Edema is very common in heart failure. Difficulty lying flat or orthopnea, it's common with heart failure. Waking up at night, short of breath, also common with heart failure. Coughing at night, and overall fatigue and lower energy. That's a non-specific symptom. That could be associated with a lot of different conditions, but when in the right clinical context, that could be heart failure as well. And even inability to complete a full meal. Sometimes when the body is swollen, the gut is swollen as well. And you can't finish a meal because you feel so bloated and so heavy because of all the fluid retention. And so you can imagine if you have those symptoms, you feel pretty poorly. So what can we do to make you feel better? How do we get these patients feeling better? No longer short of breath, able to complete a meal, no more swelling. Well, as I alluded to previously, the treatment depends on the type of heart failure you have. Strong hearts get one type of treatment. Weak hearts often get a different type of treatment. Many patients, in fact, most patients will require diuretics. Diuretics are often called water pills. These pills allow patients to get rid of the extra fluid by urinating it off and then keeping it off. The most common names of these drugs that you might recognize if you're on them: furosemide, which is Lasix, torsemide, also called Demodex, and bumetanide, which is Bumix. They're all cousins of sorts in a family of drugs called loop diuretics, and they all work relatively well to remove extra fluid in patients that have normally functioning kidneys. Some patients need regularly scheduled diuretics. Some only take diuretics as needed. And some patients need diuretics only after they do something they weren't supposed to, like eat at, let's say, Golden Corral. So if your ejection fraction is preserved, which is normal or close to normal, the treatment is primarily based on modifying risk factors and removing the volume with diuretics. So with heart failure with preserved ejection fraction, there really is no magic bullet. We use the diuretics to manage the fluid. We manage the hypertension. We treat any abnormal heart rhythms if there are there. We treat the coronary disease if it exists. We treat obstructive sleep apnea if it exists, very common comorbidity. We control the diabetes, and we talk about weight loss and dietary modification because many of these patients with preserved ejection fraction struggle with obesity. Clinical trials are underway for new drugs in this subset, but primarily it's management of comorbidities and using the loop diuretic to manage the congestion. No magic bullet here, unfortunately. With heart failure and reduced ejection fraction, specifically that's an ejection fraction less than 40%, we do have a specific set of drugs that we can use, and I like to use a football metaphor, which I'll show you on the next slide. These medications individually and collectively prolong survival, they reduce rehospitalizations, and they improve quality of life. So the goal of any heart failure practitioner is to get the patients on these meds, this cocktail of medications, and then we actually titrate up the medications to the highest doses that the patient can tolerate. By titrating up these meds, we know that the outcomes are better in the long term. There are also devices to consider for these patients. These devices actually prevent sudden cardiac death, and actually these devices often make patients feel better. So there are 4 classes of drugs that your doctor should be thinking about if your heart is weak and you have symptoms. And the 4th is actually relatively new. If I'd given this talk a year ago, I probably would have said 3 classes, but now we have 4. 4 that everybody should be thinking about. The first class, and going back to this football metaphor, this is your helmet, okay? Entresto. Entresto is a medication that's been around about 5 or 6 years. We used to only use it in certain patients, but the data has evolved in that everybody with a weak heart should be on this medication if they can tolerate it. It's an excellent medication for heart failure. Many patients feel better. Patients that tolerate this med at the top dose, in my experience, all of them do exceptionally well. So Entresto, Entresto, Entresto. And I don't work for the Entresto people. It's just a good drug. There are people who cannot tolerate Entresto for whatever reason, and so ACE inhibitors and angiotensin II receptor blockers are acceptable alternatives. Those medicines, if you guys are on those, lisinopril, ramipril, enalapril, those are ACE inhibitors, and then the angiotensin II receptor blockers, those usually end in sartan, so losartan, valsartan, candesartan, those are angiotensin II receptor blockers. Those medicines are good second agents, but the best agent in this class would be Entresto. Again, that's your helmet if you're a football player. Now we're moving on to the shoulder pads. All right. And that's the class of drugs called beta blockers. Beta blockers relax the heart, allow the heart to recover with time, make the heart stronger with time, and reduce sudden cardiac death and prolong survival. 3 specific beta blockers have been studied in the heart failure population: carvedilol, metoprolol succinate, and bisoprolol. These medications, in conjunction with Entresto, are excellent for all heart failure patients, and everybody with a symptom with a weak heart should be on them unless they can't tolerate them. Now we got our cleats, and that class of drugs is called the mineralocorticoid antagonists. Only 2 in this class, eplerenone and spironolactone. These 2 drugs have been developed specifically for other causes, but they've been studied in heart failure and found to be particularly effective in prolonging survival and in reducing rehospitalization. So everybody should have these 3. And then the 4th class, which is new, is actually a class of drugs that was initially developed for diabetes, but over the last year, we've seen a lot of very strong positive data in the direction of heart failure patients. And so if you have heart failure with a reduced ejection fraction, and particularly if you have diabetes, but even if you don't have diabetes, these medications are likely beneficial, and I've been starting on my patients on them, and I've had a beneficial effect. Farxiga is one of these drugs, and Jardiance is the other. So I use the metaphor again of football, and here's my favorite football player. This is Barry Sanders here. You can see Barry here. He's got his helmet. He's got his shoulder pads on. He's got his thigh pads on. He's got his cleats on, and he's avoiding tacklers, just like these medications help us avoid hospitalizations and worsening survival in heart failure. I use this with my patients, and I think they seem to appreciate it. And what about devices? Well, patients with an ejection fraction of less than 35%, they actually have an increased risk of sudden cardiac death, meaning everything can be all okay, and then you go to sleep at home one night and you never wake up. And it's just because the heart's not normal, and abnormal hearts tend to not work at times if you compare them to a population with normal hearts. These patients literally they'll go to sleep and never wake up. And so we use devices in this population called defibrillators to reduce the risk of sudden cardiac death. So an internal defibrillator can prevent this from happening to you. It can actually save your life. So if you look at the image on the screen, this is a chest x-ray of a patient that has a type of defibrillator called a CRT, cardiac resynchronization therapy. And on the top right, that's the actual defibrillator. The leads are tunneled into this patient's heart. And with those leads and the defibrillator capability, the heart can often get stronger and certainly will reduce the risk of sudden cardiac death. So a different type of cardiologist, a cardiac electrophysiologist, will implant this type of device. And if you've been on the right medications for 3 months and your heart's still weak, you might need one of those things. So if think about it, how long has your heart been weak? Do you have a defibrillator? If not, you might need one. And of course, to know that, you have to know what's your ejection fraction. So I wanted to spend some time just talking about what heart failure progression looks like over the years. And so if you start in the top left of this figure here, at the beginning of the disease process, patients typically feel well. They might end up in the hospital at some time, often at the time of diagnosis. And once they leave the hospital, they typically feel better. We can usually get them on the right meds and they feel okay. But as the years progress, the functionality gets worse, possibly hospitalized again. And then at the end of the year, end of the disease process on the far right of the slide, you get to the point where you're feeling so poorly, extraordinarily poorly, and then the last step, of course, in the disease progression is death. So if this disease is left untreated, it will cause mortality in everyone unless they die from something else first. And so many of my my patients ask me, how do I stay on the top left of this graph? How do I stay at a point where my activity level is normal or near normal for me? And how do I avoid ending up on the bottom right? How do we do that? So what do I need to do in order to do well over time? Well, first and foremost, there's medication adherence. The doctors need to put you on the right medicines, and you need to take the right medicines. You need to make all your appointments with your healthcare providers. Get the right device, as we talked about. We want to prevent sudden cardiac death with our defibrillators. Adhere to the right diet, which would be a low salt, fluid restricted diet. You need to weigh yourself regularly. Exercise helps. We actually have clinical trial data that tells us that heart failure patients that exercise, they do better than the ones that don't. We usually say 3 to 5 days a week, mild to moderate exercise. And then, of course, quit smoking. So delving into the diet a little bit, what can I eat? Well, there's been some controversial data on this over the years, but it is my opinion that a low sodium diet really does help. Less salt in the diet minimizes the risk of fluid retention, in my opinion, and minimizes the risk that you're going to end up in the hospital swollen and short of breath. In particular, heart failure patients should work to minimize their salt intake to less than 2 grams or 2,000 milligrams in a day. Excess salt causes water retention, and the water retention leads to worsening heart failure symptoms in many patients. So what exactly is a low sodium diet, or what do you need to do? Well, first off, you should never really add salt to food. I mean, I tell my patients, you need to kind of think about salt as an allergy. You kind of think about it, I'm allergic to salt. I can't add it because that's going to do me harm. You also should avoid frozen meals, canned foods, fast foods, and what we call convenient foods. Anything that's, really easy to eat out of a bag, processed. Most of the time, that stuff is going to be high in sodium. And thirdly, start reading labels. So for folks that do read labels and that really pay attention to the salt, you'll find that in the American diet, it is very difficult to keep your sodium intake down to less than 2,000 milligrams or 2 grams a day. And you'll see by reading the labels, you'll see what is high in salt and what's low in salt. And over time, you can modify your diet to the point where you're not miserable every day because you're not eating anything you want, but you're eating things in moderation and minimizing the things that are actually high in salt. It is a struggle, but it can be done. The patients that do it typically do well. There's lots of information online on how to actually get to a low sodium diet. But that is something that is a key to success in heart failure patients, in my opinion. Moving along, what about drinking? What can you drink? Well, here you see a picture of a squirt bottle on the page, a 2-liter bottle of squirt. I'm not showing you this because I'm advertising squirt, although I do like squirt, although I gave it up. I'm showing you this to give you a sense for what 2 liters is. So in general, we ask heart failure patients to restrict their fluid to less than 2 liters a day. Some heart failure patients, believe it or not, have a tendency to drink excessive fluid, more than 4 liters per day. I mean, that's actually 2-liter bottles of soda, which is a tremendous amount of fluid. And of course, when patients struggle with fluid retention, the more fluid they take in, the more fluid they're going to retain, particularly in the context of a high sodium diet as well. And so I tell my patients to drink solely to quench thirst. If you drink solely to quench thirst, you will almost always drink less than 2 liters of fluid per day. Some patients carry around bottles. Some patients, they have their ways of limiting their fluid intake. But in general, we want to restrict that fluid intake to less than 2 liters a day. That is a key to being successful in terms of fluid restriction. And then daily weights. I mentioned daily weights earlier. So why do I need to weigh myself daily? Well, sudden changes in weight can mean more fluids actually building up in your body. Sometimes that's caloric weight, particularly if you're not moving around much and eating heavily, like a lot of folks have been doing in the COVID pandemic. But oftentimes that weight gain is fluid weight in heart failure patients. And that the first marker that you might be slipping back into worsening heart failure is weight gain. And if it's not treated soon enough, sometimes it leads to a hospitalization. We'd like patients to weigh themselves at the same time each day. I tell patients, weigh yourself in the morning, before you use the bathroom, before you eat. Same type of clothes, just to make sure that the baseline is the same every morning. You're comparing apples to apples and not apples to oranges. Also would like to use the same scale as well. And then we ask patients to write down their weight daily using a calendar or chart. Some patients do this in the beginning. They don't necessarily need to do this for the rest of their lives. But in the beginning of the disease, it often helps. So you get used to looking at your weight and paying attention to how much you weigh, because again, sometimes this is the first sign of fluid retention, even before you have any symptoms. And for most people, gaining 3 pounds overnight or 5 pounds over the course of 3 days is cause for alarm. Now, smaller people are going to gain less weight and bigger people are going to gain more weight. So if you're 350 pounds, maybe 3 pounds overnight for you is not a big deal. But if you're 125 pounds, it probably is. So you have to kind of pay attention to it and look at what your weight does on a day-to-day basis. Starting to pay attention to that can help many patients. Moving on to exercise. So exercise is good. And I think we all know this, but it's good to hear somebody tell us this again. So in terms of frequency, we say 3 to 5 times a week, ideally. You don't have to exercise every single day, but 3 to 5 times a week is an excellent target. In terms of intensity, we actually like mild to moderate exercise as opposed to highly, highly intense exercise. So we have this term we use called the talk test. If you can talk while you're exercising, that's probably sufficient. If you cannot talk, if you're so winded, you're so out of breath, you're gasping for air, you're panting while you're trying to exercise, it probably means you're doing too much. So mild to moderate exercise is certainly acceptable in heart failure patients. And again, we have data to say that it helps. In terms of time, we say 30 to 45 minutes of continuous aerobic activity. And we want aerobic activity, so not necessarily heavy weightlifting or things that are grunting and graining and anaerobic activity. We want continuous exercise, so walking, biking, dancing, hiking, swimming, those types of things. And for those of you that aren't aware, we have a physical location that heart failure patients can go to called cardiac rehab. So cardiac rehab is something that I really, really am a fan of. Wellstar has cardiac rehab centers all across Cobb County, the region, where heart failure patients can go. They exercise in a monitored setting. They progress over time, and you really can track your progress. And many of my patients have done exceptionally well with cardiac rehab. So if you don't feel comfortable exercising on your own in the beginning, maybe you can get plugged into cardiac rehab, specifically if you've been recently hospitalized. So again, the formula for success here: medication adherence, making all the appointments, getting the right device, a low salt diet, fluid moderation, treatment of all the comorbidities such as sleep apnea, diabetes, obesity, etc. And then what if you do this and you're still not feeling well? Well, then you really depend on the multidisciplinary team to get you to who you need to get to. So most heart failure patients are being taken care of by primary care doctors and general cardiologists. We get the electrophysiologists involved to implant the right device, but the day-to-day ins and outs of heart failure usually are not done by an electrophysiologist, sometimes, but not usually. And if this part of the team is doing everything right, and the patient's still not doing well, the next step in the team is the advanced heart failure specialist. And that's really what I do. As an advanced heart failure specialist, I'm going to take a little bit of a different look at everything and really make sure that the patient is getting the right care. And so advanced heart failure specialists will rule out sophisticated or rare, unique diagnoses. We'll also assess patients for candidacy for special devices, special medications, and even clinical trials. And then we also, most importantly maybe, evaluate the need for advanced therapy. So some patients are just so sick that no matter what they do and no matter what anybody else does, they're just not going to feel well. And those patients, unfortunately, are at risk of imminently, dying over the next year or two if we can't get them to their definitive therapy. And those definitive therapies would include a transplant and an LVAD, which is a mechanical pump that supports the heart. So heart failure is really a team effort. It's really a team effort. You can't do this by yourself. You are the key player. But other team members include physicians, nurses, social workers, pharmacists, and even behavioral health specialists. The team will fail if the patient isn't in the game, so it's got to be a joint effort. So the Wellstar heart failure team is really set up for this. We have a clinic here in Marietta. We call it our comprehensive care clinic. The contact information is here. We have physicians, nurse practitioners, nurses that are specialized in heart failure management, pharmacists, social workers, behavioral health specialists, all in one place. And we really focus on specifically on the care of our heart failure patients. Lastly, support groups. So many of my patients have asked me about, well, I know I have heart failure, but I don't know anybody else with heart failure. How do I get plugged in? And in looking for the answer to this question, I found that there isn't too much online. I found these two sites that actually, and I looked into it, they seem to be have good information there. So we have two sites there. And then within Wellstar, we have something called the Heart Failure Academy. And we can share more information about that if you end up contacting our comprehensive care clinic. With the right care, you can do well, and I'm sure of it.
For additional support, please feel free to reach out to us for wellness coaching. Our contact information can be found here, and we look forward to working with you. Thank you, and be well.